Hello and welcome to Health Styles. I'm Connie Mead. We all know that certain diseases tend to run in families. Perhaps your family has a high incidence of heart disease or, say, colorectal cancer. Well, the good news here is that in these cases, you can often take positive steps to prevent your risk of developing these diseases. But what if your family disease is truly genetic, in that if you are born with a certain set of genes, you will definitely develop the disease? Well, that is the case with Huntington's disease, and today and over the course of our next program, we will be looking closer at Huntington's disease and trying to understand more about it and to understand the obstacles it presents the families dealing with it. Joining me today for our discussion, we have three guests, and the first is Dr. Samuel Frank, who is an associate professor of neurology at Boston University and the Boston Medical Center. He is also the chair of the center's Program and Education Advisory Committee, and he is a board member of the Huntington's Disease Association of America. And along with Dr. Frank, we have Karen Baker, who is the New England Regional Social Worker for the Huntington's Disease Society of America. And we have Virginia Goolkasian, who is the manager, or the director, I should say, for the New England and Greater Albany, New York regions of the Huntington's Disease Association of America. I want to thank you all for joining me today and being here to discuss this subject.
Well, thank you for having us.
Thank you.
Okay, well, my pleasure. Let's start with Dr. Frank and find out exactly what Huntington's disease is. Can you give us sort of a snapshot so we can, for those of us who don't know what it is?
Sure. Well, I mean, it is a rare disease, so most people don't know what Huntington's disease is. It's an inherited progressive brain disorder that causes problems with movement, problems with thinking, and problems with behavior. It typically starts in the 30s and 40s, but it can be a pediatric disease and it can be a geriatric disease, so it can start any time in life, but typically in the 30s and 40s. And it is inherited, so you have a parent that has it in most cases. And if you have a parent that has it, you have a 50% chance of inheriting it yourself. It is progressive over a few decades and is invariably fatal.
Okay, so you say that it can happen at different stages of life, but once you start showing symptoms, it progresses from there. It doesn't go into remission or anything, come back later or anything like that?
Unfortunately, there is no remission. It's
Okay.
really invariably progressive to the point of death. And there's no way to delay the onset or to slow the progression that we know of at this point.
Okay, and so the average age of onset is about?
It's in the late 30s.
Okay, and how long is someone usually ill with it before they pass away from it?
It's about 20 years, but it's completely variable. Sometimes it's less than that, sometimes it's more than that. That's on average.
Okay. So does it strike certain ethnicities or genders, or is it random or what?
It doesn't care what ethnicity you are.
Okay.
It will impact you if it's in your family. So I have patients from around the world that have been impacted by Huntington's disease. It's completely genetic and not related to any ethnicity, male or female. If you have a first-degree relative, meaning a parent or sibling with it, you're at risk for getting it as well.
Okay. So if you had a grandparent, though, so yeah, let's talk about the genetics a little bit
Sure.
so that we understand sort of who might develop it.
Yeah, so it's carried on the 4th chromosome, so it's not an X or Y chromosome. So again, it's not related to male or female. And you get one copy of your 4th chromosome from your mom and one from your dad. That puts your 2 chromosomes together. You only need one copy of the gene that will give you Huntington's disease to develop Huntington. So that's called autosomal dominant. autosomal because it's not related to the X or Y chromosomes, and dominant because you only need one copy and it does not skip generations. So if your grandparent has it and your parent has it, then you are at risk for getting it as well.
Okay. If your grandparent has it and your parent doesn't have it, you will not develop it.
That's right. So if it doesn't continue down a family line, it's not going to start up again.
Okay. Okay. So it's not a recessive. It's probably the dominant thing there
That's
too
exactly
as well.
right. Recessive, you need 2 copies of a gene, and in that case, you could have a family member that has it, or a parent or grandparent, and you may not get it. You need someone along the line needs to pick up a second copy.
Right, okay, but you just need the one copy and then it goes down that line.
Right, and so sometimes you just need one copy of a gene and it's also called autosomal dominant, but there's also how much that gene is expressed in the body, or how much it impacts you as an individual. And Huntington's is, it's 100% penetrance. It means if you get the gene, you're going to get the disease.
Okay, okay. So oftentimes people who develop Huntington's have known their parent has had this disease as well, correct?
That's correct.
Yes.
Yeah. So it often does run in families that way. It may not always necessarily be diagnosed that way. I've had people come in that say, well, I have Parkinson's that runs in my family, and it turns out it's not Parkinson's, or another genetic disorder, that, or a non-genetic disorder that they say runs in the family. But often there's something that's known that happens in the family.
Okay. And I suppose maybe the later in life it happens, maybe the more confusing it is. Can that be the case?
Absolutely.
You know?
I had a patient yesterday, in fact, whose mother wasn't diagnosed till she was 70. She was showing symptoms before that, but it wasn't really known in that family up until that point. So it was confusing because it was later than the usual age of the 30s. If it presents in the 30s and you know that there's a parent, a grandparent, multiple aunts, uncles that have it, it becomes very clear. So it's the unusual cases where it's later onset that it becomes more of an issue in terms of diagnosis, and it gets a little more confusing. It's a little more implications for the family too, because at that point, if you're diagnosed at 70, chances are you've already had kids, you already have grandkids, and you have lots of nieces and nephews and grandnieces and grandnephews.
Right, so that gene may be continuing.
Exactly.
Right. So now, I know we'll probably talk about this more when we do the second show too, but since we're talking about it a little bit now. So in terms of genetics and what we can see now with, you know, before a child is born, let's say, you know, you can do prenatal testing, you can do in vitro fertilization. Do you see that there'll be fewer cases, or is it?
I sure hope so. That would be nice. And more people are choosing to get tested at ages where they're making decisions about their life, whether it's career or family. And when it comes to family, you can do pre-implantation genetic diagnosis, or PGD, and that's testing an embryo and only implanting those that are gene negative. Some people choose to move forward with the pregnancy and have amniocentesis and then can terminate that pregnancy if it's positive. There are other options, but those are the main ones that people choose if they're going to have their own genetic kids.
I see.
And so still, though, only about 1 in 6 people choose to get tested in terms of the gene, because there's not a whole lot that we can do about it before people develop symptoms. So it's a clear minority of people that get tested, even though if everyone got tested and had kids without the gene, we could certainly reduce the number of people that have the disease, but we couldn't eliminate it completely.
Right, and maybe not everybody has access to the testing either. You know.
It's pretty widely available at this point, and unfortunately sometimes it's done in situations that are inappropriate too. So it really needs to be done with people who know about Huntington's disease and know about the implications of the testing too.
Okay, well, let's talk a little bit more about the symptoms and everything. I know that you say it affects muscular behavior. What else? Mental behavior, and what else?
So the 3 main aspects are motor or movement problems, cognition, more along the lines of dementia, and behavior or psychiatric manifestations. In terms of the movement side of the disease, the classic finding is chorea, which translates from Greek for dance. And so it's a flowing type of movement that, and it's an involuntary movement that people get. They also can have dystonia or excessive muscle contractions around a joint. They can have slowness of movement, they can have tics, myoclonus, all different types of movements, but chorea is really the main movement that people get. And a lack of voluntary movement is important to consider with that too, or coordination problems can happen. In terms of the cognition, often it's not what we think of as Alzheimer's type disease, although they can get that later in the disease. It's more of what we call subcortical, or the deeper structures of the brain that are impacted, which causes a slowness of thinking. So you ask someone a question and it may take them a little longer to respond or to come up with the word or the right set of responses that they're looking for. In terms of the behavioral manifestation, people can be impulsive, they can have poor attention, and they can have depression and anxiety. And so that often is a huge issue even before people get diagnosed from a motor side of things, of the disease, and can be addressed with usual treatments.
Okay, so there are medications that can help all of these three things?
Yeah, so not so much on the cognition side of things.
Okay,
That's more environmental and behavioral manifestations, having
right.
lists up in the house, having a routine, that kind of a intervention. But depression, we use the usual medications that we use for depression, and cognitive interventions as well. And from the movement side of things, we can certainly suppress movements and treat some of the dystonias as well. So there are some symptomatic treatments.
Okay, all right. So when somebody receives this sort of diagnosis, is it usually overwhelming for them? I mean, and maybe Karen can talk about that as well. Is it an overwhelming diagnosis for many of these people when they find out that they are facing
I think
this?
so, and that's if people choose to find out. Many people are afraid to test. Many people know that there are not just their fears about testing, but there's some very real issues about discrimination. If you test positive for this disease before you have bought a life insurance policy or long-term care insurance policy, you can be turned down for buying those financial products. People fear that if this gets out at their job, they'll lose their job. A girlfriend, boyfriend, spouse might leave them. So the discrimination is very real. So people do have a reason for proceeding cautiously with this.
So you're not talking about just testing to find out if you have the gene. We're not talking about that. We're talking about somebody who has been diagnosed. Even at that stage, you're saying people tend to keep it quiet? Is that what you're saying? Okay,
yes.
Because they're afraid of discrimination.
But yes, so it's very real, the discrimination that people feel about this disease, the judgment. People feel that they're judged for having children, that they're judged that they should have known about the disease. And I find it interesting that many people don't know it's in their family. When people look back on their family history, they might have been put up for adoption. A parent might have died in a car accident or from cancer or in the military prior to the start of the symptoms. And many people also look back, and they look back at grandparents that nobody talked about it. People were just sent to a state hospital or sent to a nursing home. So people are without their awareness of what their family history, medical history is. So many people can be dreading it, but there are just as many people that don't know at all and are shocked.
Right, sort of out of the blue. They get this diagnosis.
Yeah, and I'm not sure what's worse, to spend your whole life dreading that you might have this disease, or to be shocked and unprepared for it.
Right.
There is a concern that if people test positive and find out the results, that they're at risk for suicide. We do want to be open about that, that there is help for those feelings of depression, counseling, suicide hotlines, support groups, medication. So we do want to be open about that and aware that it is a huge, very upsetting thing to find out, and we want to help people deal with it.
Just one other word on the suicide aspect of things. We find that people that actually choose to get tested 1 year later have lower incidence of depression and suicide. The peak suicide is just before people get the diagnosis. So maybe they recognize it in another family member and they recognize it in themselves. So just before diagnosis, and as people transition between stages and they start losing function, if they can't work anymore, can't drive, those are the two peaks of suicide. But depression and impulsivity is a bad combination when it comes to Huntington's disease, and we do need to monitor for a suicide in all patients.
But it sounds like they can get through that period, maybe, get over that initial
Yeah,
hump.
so we're talking.
They do better?
Part of the confusion is that we're talking about gene testing, which can be done anytime in life, really. As soon as there's an embryo, you can test genes.
Right.
But that's different than a diagnosis of the disease.
Right.
And so gene testing can be done when people are not symptomatic, have no problems whatsoever cognitively, behaviorally, or in the motor sense, and you can find out if you have the gene or not. That's where I'm talking about that people actually 1 year later have less depression and less tendency towards suicide.
I see.
In terms of the motor onset, that's when people have obvious symptoms. And you can diagnose the disease even without the gene test if it's a clear family history and clear typical symptoms at a typical age of onset.
Okay. And then somebody with a diagnosis at that point might become very depressed and be at risk for suicide.
Yes.
You would say. Okay.
Yeah. And that's why HDSA recommends that people use a source for testing of it, as you said, a doctor who's very familiar with HD, not just to give them the result, but to provide the follow-up care, referrals for support groups, for counseling, to work with the family to provide support. We don't want people to just get a result and have no follow-up and no support.